Okay, I want to say hello. I'm Bob Dempsey, and once again, we're doing our update on the COVID crisis. And indeed, we are in the middle of a crisis. But as always, I'm going to end up by saying that there's light at the end of the tunnel, and it comes from us working together. So I'm going to outline where we are, what we're doing, sort of the short term here, and what has become the big topic of the day, which is vaccines. And I'm going to try to explain that again so we make some sense of where we are, what the possibilities are. First of all, the surge has been so bad that we've been able to test vaccines faster than we thought. In April, I predicted we'd have a vaccine by the end of the year, and I thought I was crazy. But it was mainly because of the amount of science which was being put to bear on this problem that I thought it was possible. Not necessarily rolled out, everybody treated, etc., but something there. And so that's a big report. That is the happy news of the week. The sad news is that the US by far leads the world in COVID. We've got 56 million people worldwide have been infected, and too many, way out of proportion from the US. That was avoidable. We will still continue to try to avoid it. And Wisconsin is now the center of one of the major hotspots in the world. You look at the maps of COVID density, Wisconsin is basically blacked out. We have about 68,000 people hospitalized in the United States. Every day is a new record, and every single state in the country is rising in COVID. Nobody is still doing well. All the more reason we've got to keep it together. We've got to do what we can do. We've got to have a logical solution. And during the same time, we take care of our own patients. So to give some perspective to this, we assess, one of the assessments of how severe the situation is the degree of tests which are positive. The state of New York right now says if they get up to 3% of the tests they do being positive, they're going to shut it all down, close the schools, etc. That's ludicrous. Wisconsin's at 36%. We are 10, 12 times higher than other states' emergency areas. That's where we are, okay? And the hospitals are being stressed. I said many months ago, one of our great strengths are we're surrounded by phenomenal large hospitals. Well, even that's being stressed. We have 82 COVID patients today in the university hospital, 32 of which are in the ICU. That's a high percentage. Our partners, 61 at Meriter, 85 at Swedes, everybody's sharing the load. And the state hospitalization will overcome our ICUs. That's a big issue for neurosurgery because we've been giving up ICU beds to try to make room for patients. We understand that, it's important, but it's a big issue. So what are we going to do? We're restricting ORs. We are rationing patients. We are triaging patients. We did it before in April. We're trying to do it much more sensibly now. We have cut our OR schedule for the next couple weeks in half, and we will get down below 40%. Emergencies will still come. We will take care of strokes and tumors, absolutely, but it's getting harder because we're trying to make room for COVID patients. We're trying to restrict the number of ICU beds we use, and we have to remember that as COVID becomes so positive, like 1 in 30 people that you meet on the street are carrying it without knowing it. That's that common. That means our nurses are getting sick, and therefore our staffing levels are down. And neurosurgery is not a big field. A few providers out and we're in trouble. So we have to follow the rules. As we restrict them to what's important to make sure no patient is harmed, it means we all have to work together to not lose any patients. This is where the staff, the nurses, the residents, the MAs, the people that man the desks, the people that clean the rooms are way more important than the doctors. It's always been true, but I want you to understand it's even more true now. because by restricting access, we're trying to save ICU beds for the sickest people, whether they have COVID or not, then save staff, then third, save general care beds. This is going to go on at least till January. We're in the middle of a surge, and most surges last 3 months for this disease. So I'm really thinking it's March. But I do think, especially if you look at the history, the previous pandemics, March is about the end of them because it begins to mutate, people begin to go outdoors, and by then we might have some penetration of vaccines. I'll talk at length in that. So we need everybody's help. We need to make sure every patient is covered, and we need to know people are suffering. The economy is still difficult. People are still out of work. The university will suffer a $300 million shortfall. So they're going to cut back. You really want to be in an essential department right now at the university. And welcome to neurosurgery, you're an essential department. But these deficits are going to have to be made up. And a lot of the deficits are because we have too many patients to do our normal work. And that means we have to get a state government that will actually follow the rules, mask, separate, so people don't clump together, wash your hands. It's pretty simple. So what's the light at the end of the tunnel? It's pretty significant, and I think we should talk about vaccines, refresh our collective memories on what that is, what that means, and why this might be useful in the near future. This is a cartoon of a COVID-19 virus. It has these crowns of spikes around it that make it look like a crown, hence COVID or crown. It has a coat, and this is both its strength and its weakness. And that's the key to vaccines, because you have to understand what our solution's going to be. Really straightforward, threefold. We need to make sure the virus cannot find enough new vectors. Short term, that means isolate. If the virus can't find someone to spread to, it's done. And it's done fairly quickly, within days, as the carrier either lives or dies, and if they live, their immune system is wiping out the virus in them. 2, the virus over time, and this virus has been going at this for a year, it mutates. This one mutated to be less deadly, but more catchy, more virulent, not virulent, but more transmittable. If it can lose both infectivity and virulence, that would be lucky. And the rules of mutation are good and bad mutations happen, but usually they begin to disable the host. And 3, vaccines. So we need to figure out how vaccines work. If you look at this virus, the glycoprotein spike is unique to this class of viruses. That's important. The membrane proteins are unique. And of course, the sequence of RNA is unique. So how does it work? It uses those spikes to attach to a cell. Some cells it's more susceptible to attaching to. COVID likes respiratory cells, but it also attaches to vessel cells, brain cells, kidney cells, heart cells. It can do all that, but it's best at respiratory cells. It sticks, it inserts its RNA, in this case RNA for this. There are viruses that are DNA, this one's an RNA. It teaches the cell to make copies of itself. So it takes over the things that this respiratory cell thought it was making mucus to keep your lungs clear, and instead it makes viruses until it fills it, ruptures it, and these infected particles go out. Okay? How do you get better? How do people get better? Well, their immune system. And that's what we try to hijack to really increase the immune system to knock out the virus. What it does is it sees something as different, a virus. It marks it. It has basically presenter cells, which present these to their immune cells. This is different. The immune cells are then energized to make 2 types, T and B cells in the immune system. The T that can literally engulf and destroy not only the foreigner, but also the infected cell, which is now marked by these viruses, and the B cells, which make antibodies which stick to the outside of the virus, making it susceptible to be engulfed and not able to stick to the respiratory cells. That's how you normally clear your viruses when you get a cold, when you get the flu, and when most people, 85%, get coronavirus. However, if we could teach the immune system that this is the wrong thing, we could do it. That's a vaccine. Vaccines are of many types, each with different successes. The most common, take the virus and disable it, make it less virulent, and then they give it to you. You make the virus, but you don't get as sick. Your immune system gets energized, and when the true virus, not the vaccine weakened virus, comes, you get rid of it. There's possibility for error there. One, you have to make a lot of virus to make so it's a lot of viruses being grown in eggs. Two, you might not have made it weak enough, and your injection may make people sick. That has happened. Or you could take the virus and kill it and just have the dead virus particles there to be presented. There are problems with that. Is it all dead? Is it able to create an immune response? Now, a very important new thing has happened this year, and that's part of this tremendous push to get the vaccine in a year. The world record for a vaccine prior to this was 4 years. That was the mumps vaccine. But right now, because the government is saying, we'll pay for you to try this and that and that and that technique, and if you have something promising, we'll make 200 million doses and we'll give it out free. That's what the government has said. So as a result, many companies worldwide have 38 different vaccines which are being safety tested, 14 which are into elevated safety tests, 11 which are into efficacy. So first is it safe? Because if this is misinterpreted, as for example, if you were to have something that looks like collagen, all your patients could attack their joints. Or if it looks like myelin, all of their patients could attack their nerves. These are problems with previous vaccines. 6 are past the efficacy and into early use. 2 are what we're going to talk about today, and none of them have been fully approved. However, the 2 that are the front runners, the Pfizer and the Moderna, are very important because they use the modern science. As opposed to taking a full virus and growing it in eggs, etc., they said, wait a minute, we can sequence the human genome. Why don't we sequence the virus? We had the genome of coronavirus sequenced before it even came to the United States. So what these people have been doing is they've been saying, I'm just going to take the snippet of RNA from its sequence and take the snippet that makes the spike protein, inject that into somebody so they'll see spike proteins being made. That's what your cell would make. And that will look foreign. It'll train your immune system when they see a spike protein to wipe it out. And so the idea being that it's really hard to get coronavirus from just the spike protein, but they have to be precise about the RNA, and that protein better not look like something that you use, like your heart valve or your collagen or your myelin, or else it will attack you. So that's where efficacy and safety are important. And the other thing is the reaction, the antibodies, this cannot be so overwhelming that it makes you so sick you don't survive beyond the age of 60. And that's one of the real secrets of why the virus in April was so deadly. Your response to it was killing you. And now we are beginning to realize how to tamp that down. So the 2 trials, Pfizer and Moderna, use these techniques. They both claim above 90% efficacious. That means they don't just simply make antibodies. We saw that with others. But these patients, when injected, have 20-fold less infections out in society than the people that are injected with placebo. And what that means is it appears to be efficacious. We are now rushing it, and rushing its concern. But it is possible that by next month, there'll be 20, I'm not exactly sure how many, a large number of doses available, which will first be rolled out to first-line medical workers. I think 20 million. Both of these take 2 doses about 3 weeks apart. So in other words, you build this antibody resistance up slowly because we don't want to overdo the response. And if that works on the frontline workers who are being exposed to COVID and we keep them safe, it will be able to be rolled out by April to everybody sequentially. They'll go from frontline workers to the most susceptible patients, immunosuppressed cancer patients, elderly patients, etc. And this is an ethical challenge. Who gets it first? Who gets it last? Because of the need to understand that the frontline worker is going to be part of the safety test as well. You may want to just mask and isolate until it's clear and then get it in March or something like that. But it's really important that this may be the light at the end of the tunnel that we were talking about. It's really important that it doesn't replace masks and isolation. It's really important we tell our politicians that, because we have to get there and we have to keep the hospital from being overrun in the next days, because we've got a potential for cure in April. A potential, not a certainty, but it does look promising. There are differences between these. One has to be stored extremely cold. One can be stored in normal freezers. That's an advantage for one. But remember, there are 36 other ones. And I doubt very much that we're all going to be injected with the same vaccine. There's going to be some trial. And we won't really know till 2-3 years from now which was really the best one, the one we'll keep, just like we generally have one polio vaccine, one smallpox vaccine. So what does all this mean for us? 1, we have hope. 2, we have responsibilities. We're all in it together, every single person, the farmer, the person, thank God for them, that cleans up the hospital, because they are wiping off virus for us. The nurses, the staff, the radiologist, all of us. But mostly you. Think of what you're doing. You may be scheduling patients. You may be keeping them safe that way. You may be finding them when they're postponed. Or you may be providing direct care. We're all in it together. And we can do it because we continue to do our work. We teach, we write, we prepare grants and papers. It's very important. And we keep track of our postponed patients. We look after each other. If that neighbor of yours is elderly, you're going shopping, call them up, see if you can drop their shopping, their food on their front porch. Wear gloves so they do not fear that. Can you keep them elderly from being isolated? Can you keep them from being depressed? Can you do your work? What about yourself? Take care of yourself. I'd like to say that I had my picture of cross-country skiing up, but I don't have it here. But we did put the bike on rollers for the basement for winter. Get out, learn to cross-country ski. You'd be amazed at how beautiful the state is in winter. You'll get your exercise. You'll feel like you're part of it. And learn from this. I'm learning every day how proud I am of everybody, how much we can learn from our challenges. Take care of yourself, take care of each other. I know a lot of us are frightened and worried about what will the future bring. This is a crisis. We've been through many. And I want to remind you of some advantage you have over your brothers and sisters, over your friends and relatives. Because if you want to position yourself for the future in uncertain times, you want to be part of something that is done well, that's very needed, and very few people can do it. And I've just described neurosurgery. And you're part of that because we do it very well. It's very necessary. It's going to be here and be important. And very few people can do that. But with your help, we do. So please be proud of yourselves. Be optimistic about these vaccines. It is time to be optimistic. Talk to each other, your neighbors, for goodness sakes, your legislatures, to have common sense. We need to take care of each other by isolating, masking, washing our hands. We need to do this through and past the vaccination stage, because this virus needs help to go away. And we can do it by not allowing it access to people. And take care of yourselves and the people you care about and the people you don't even know are out there. Thanks for all you do. I appreciate it very much.